I really need you to be quiet because I can't hear this. I don't think it's started just yet. No, it has toggle where they are. There's that black sticker on top of the dress. You know, today, can I just change the volume with this? Yeah. Okay. I'm going to go check. That's not what I expected in those questions. That's a hundred? Yeah. I didn't know you put that. Does anybody have a pen I can borrow?
Trevor, you need to go count your carbs. Okay, did you already fix your plate?
Oh, no.
You already gave it for 72? Okay. Okay, good. Okay. Go ahead and fix your plate what you gave it for, okay? So hungry? You know you can sit in on the webinar by listening on that phone. That way, if I for some reason, you'll know.
calling. I couldn't find anywhere to set up. Wait.
Come here, little kid. Nah. And it said, push pound 6 to unmute. Now we're on speakerphone.
Why is it muted?
I don't know.
Try *6.
I can hear a child talking too.
Speakerphone thing.
Somebody can hear a child talk. I can hear a child. I thought the child was there. They're setting it up now. Okay. Right. Open that thing.
That's what you were unmuting.
There's open it, and that way I can have some of that.
Here again?
Up here, baby. Somebody doesn't have their phone on mute or something.
That would be you.
Is it me? I put mine. I hit the star whatever 6.
I guess I did too. No, I don't know.
But I'm hearing
We all
children.
hear
Are there
each other?
children there? Are there children there? Because I'm hearing children. I don't have any children here.
I don't have any here either.
Okay, I thought maybe y'all did, and I thought, that's where I'm hearing it from. So I'm hearing it from somebody. I hit the star.
Probably need your phones.
I hit *6 like it said, and
Mute your pound 6.
Mute your actual phone.
Mute
not the pound 6, your actual.
*6 unmute.
Okay, so hit
Have a
pound
mute
6.
button.
Hold on, let me
So
see if I can
you
see
have a mute button on your phone.
Okay, hold on. Yeah, I have one. Just punch that mute button.
Yes.
Okay.
Now talk. All right, the girl that said she could hear the child in the background is gone. I can't hear her anymore.
Welcome to today's McLean Children's Hospital webinar on how to deal with extreme sugar levels in an organized way. Dr. Stephen Burns, board certified technologist at McLean Children's Hospital. Special experience in the management of children with diabetes. From his personal standpoint, Dr. Ponder has lived with at the age of and describes himself as a soldier in the war on diabetes. He has authored many publications, receiving state and national awards, and continues to lead community service projects across the state. Dr. Ponder, please begin.
Thank you. I want to thank everybody for attending the webinar tonight. Thank you for putting up with some of these early little challenges we're having in the audio. Hopefully everybody can hear me speak. I'm going to go to another thing. Our sponsors, Baylor Scott & White Healthcare, for helping me put this on. And all of you for taking time out of your day, mornings, afternoons, or whatever time of the day it is for you, wherever you want. The title of my talk is going to be Keeping Your Child or You with Diabetes Out of the Hospital. This will be about an hour long, and I'm going to ask our moderator, Scott Clark, who just introduced me, to collect questions as they come through the chat line. And I will do my best at the end of our discussion to answer your questions. Now, some housekeeping notes about this. This webinar is being recorded, so you know. I hope you previewed the pre-webinar background materials I posted to SlideShare and YouTube over the weekend. If not, I will repost these to my Facebook page. This slide deck will also be posted to SlideShare as well. Now, where you will go to access all of these will be on my Facebook page, The Power Within by Stephen Ponder, MD. Please make sure that if you're not already have liked this page, that you like it sometime tonight so you can have access to all of these links later on. Submit your questions during the webinar to the moderator. Write them for the Q&A as well. This webinar will end promptly at 9 o'clock Central Standard Time, which is roughly an hour and a half from where we are right now. Just so you know, we will be putting on a second webinar on Tuesday, October 28th, 2014, from 6:30 to 7:30 p.m. On the topic of traveling with diabetes by my partner, Dr. Matthew Stevens. So now, without any further ado, let's get on to what I wanted to talk about tonight. I shared this over the weekend. That a lot of people have parts of their brains that they have diabetes or a child with diabetes that are dedicated to a lot of different things. I'm going to focus tonight on the management of illness, sick days, either extreme high or extreme low blood sugar. I think that's an area that needs a lot of help. So we're going to focus on that tonight. One second. Put me on the phone. Okay. Hopefully people can hear me a little bit better. There are 6 things that I think we need to really remember when we're talking about diabetes. First of all, how it works. And during the talk tonight, I'll explain a few things that are important about how type 1 diabetes works and how they relate to illness and extremes in blood sugars. The importance of water, and this will become very evident as we go through the talk a little bit further in the hour. The dual role of insulin. It has actually an on and off role, which will make more sense as we go through tonight's discussion. How the fact that most carbohydrates will turn into sugar in the human body, and how exercise is also a form of stress, and I'll discuss that in one of the questions I answered tonight as well. And it's also very important that our brains run on sugar. That's one of the reasons that diabetes causes so much grief for us, especially when our blood sugars go to the extreme. The toolkit that I'm asking you to develop here is a method, includes a method to check your blood sugars. That's very important. Most of you, hopefully by now, have a very good, sound method for doing this. Also a method to check for ketones. And notice how I spell ketones, folks. There's no Y in this word, but ketones. Whether you're measuring them in the urine or in the blood. You have to have access to liquids, both carbohydrate-containing liquids and non-carbohydrate-containing liquids. You also have to have access to fast-acting or slow-acting carbohydrates, which will be helpful as well. I'm sorry. We had a message. Somebody was not accessing the audio very well. I'll continue on. It sounds like everybody is accessing the audio. You'll need to have glucagon for injection, insulin, and a way to deliver it reliably, as well as anti-nausea medicine. These are all the things that you need to properly manage an illness or an extreme blood sugar situation. So hopefully these are things that you have in your home or have ready access to, whether at work or even on a vacation. And, of course, your wits, which will become very helpful, and maybe access to a phone if you need to in an acute emergency. The process is quite straightforward when you're managing an illness. You have to get the necessary facts, and I'll be going through some examples and we'll work through some problems in just a minute. We have to identify the immediate needs, the things that need to be done immediately, right then and there, and prioritize what needs to be done next. So prioritizing actions is extremely important, especially in states of extreme low blood sugars. Then we have to execute those actions, do them according to what we've been taught, and then as necessary, repeat these actions as needed. I think that's very important because many times we don't repeat the things that need to be done to finish the job in managing an extreme blood sugar, be it high or low. And we don't want to stop until that job is done. So this is the basic process that we will all follow through in the examples I share with you tonight. Some of the common problems in people with type 1 diabetes include, and this is not an all-inclusive list, by the way, missed insulin dosages. I myself had missed an insulin dose before. It has caused some pretty significant consequences when I was younger. Insulin dose reversals. I've had contacts from family members before, parents, where they've taken the morning dose in the evening or the evening dose in the morning and made significant reversals in dosages, which can cause significant problems. Surreptitious or hidden insulin dosages, which sometimes our kids might do, not tell us. Extra insulin dosages, for example, between meals that we're not made aware of. Use of outdated or damaged insulin. That can be a significant problem in causing high blood sugars. Any change in the routine or your preparedness, such as when you're on a vacation or if you're on a holiday, when you're off of your usual protocols that you have at home, that can throw you off base. Insulin pump, site problems, mechanical problems with the insulin pump, or even tubing problems can be major issues for control problems. Medication side effects, I'll discuss a couple of those tonight as well. Excessive stress and infections as well can also really wreak havoc with type 1 diabetes. Now, communication and observation as a parent or as a person with diabetes or somebody who has a loved one with diabetes is everything, especially in regards to low blood sugar. Now, most of you probably are fairly comfortable with the signs of low blood sugar, but let me just enumerate some of those for those of you that are not. Sweatiness, shakiness, tremor, any loss of energy or loss of interest, sleepiness, confusion, irritability, or
Get him!
Some of these may overlap with, and some of the
Use your phone.
high blood sugar can be increased thirst, going to the bathroom more often or peeing more often, headache, itchy skin, cramping muscles, and then if you actually add on the addition of ketones in the bloodstream, you've got stomach ache, nausea, vomiting, irritability or moodiness, deep breathing, and stupor. Now, these are things that can actually, some of which can overlap with low blood sugar. And it's one of the reasons why some people will actually diabetic coma, which includes both a severe low blood sugar as well as a state of diabetic.
Need to mute your phone, please.
Specific when the word diabetic coma is used. But when ketones are present, you get an array of additional signs and symptoms which need to be addressed relatively immediately. Now, many of you may go to the emergency room or the hospital, and this is a very common comment I get from parents. I get told to go to the emergency room whenever my diabetic child is sick, but they often don't seem to know as much as I do. Now, many of you might be shaking your head and saying, yes, I totally agree with that. Let me explain a little bit about how ERs work. I did spend a lot of years of my life in an emergency room. I will tell you that even today, many health professionals in emergency room settings or even outside of ER settings are somewhat uncomfortable or at times unaware of the practical side of most of our diabetes technologies. So that's our insulin pumps, our continuous glucose sensors, our meters, and so on. This can cause a lot of tension and stress for both sides of the equation here, both the doctor as well as the patient and the family. Still, most parents are directed to go to their local emergency department for all urgent problems, oftentimes no matter how minor they may appear. So just be prepared that you may be going into an area where people are not as well versed on the diabetes that you are very well knowledgeable about. So prepare yourself for these trips when you are compelled to go to the ER. Just remember that some ER doctors will sometimes want to remove an insulin pump. Now, this may be a good thing in some cases, but it also could cause problems, as many of you probably know who have experienced this, because they may be removing a source of insulin that was up until then working rather properly. And if that was done in response to a low blood sugar, that could cause high blood sugars to occur in just the next 2 or 3 hours. So just remember, be well aware of what happens when that insulin pump is
Please mute your phone.
affecting insulin, which can disappear rather rapidly. Intravenous lines in the emergency room are almost standard these days, especially in pediatric hospitals. And just a little IV sugar water can often drive up blood sugar levels rather dramatically. And a lot of times the doctors aren't really aware of how much it can drive these up. And an insulin pump or even just a baseline insulin dose such as Lantus or Levemir can't compensate for the amount of sugar just in your standard IV fluids, especially if they're running in at a rather high rate of speed. Also, most emergency room docs don't know what a continuous glucose monitor is. This is still a relatively new technology as far as modern medicine goes, and especially in emergency rooms. It's important to bring additional supplies to the hospital because you may need to anticipate the hospital at least for a day or so, which might mean bringing extra insulin pump supplies or even your insulin or other equipment just in case you might need it later. Also, just please be understanding with the doctors here. They're all trying to help, and they're doing the best they can. So good communication is key in these situations. But in most of your emergency rooms, protocols often overtake everything else. And you may have to remind the doctors sometimes the state of your child, and especially if they're on an insulin pump or some other fairly advanced technology that's helping them manage their diabetes. Withheld insulin dosages in an emergency setting can happen. It can be a significant problem, and that's important for you to keep track of when your child gets their insulin dosages in the ER, or if they don't get one that's scheduled in the emergency room. One reminder, please mute the phone. We still have somebody who's not muted on the phone, and you want to press the numbers *6, I believe, to mute. Is that right, Bob?
#6.
#6. I'm sorry, #6, please. Okay? I have one person that may still be able to hear the audio on. Now, expect your calls for emergency problems to be returned in a timely fashion, not 5 hours. So when you're calling your doctor's office or calling any sort of emergency line, please make sure that if you don't get a call returned in a timely fashion, don't wait too long. You may need to take action. So don't wait too long if your child is sick, not feeling well, and you don't get that call back. Keep trying, or if necessary, go on into the emergency department at that time. If the problem is fairly advanced, in other words, if you have somebody who's appearing to be dehydrated, having uncontrolled vomiting, you really don't have much time. You have to go ahead and take them to the emergency room or just call EMS in those situations. The point of tonight's talk is to share with you the things you need to do early. Once you start having some suspicion there may be a problem with nausea, which could cause significant vomiting, you want to get out ahead of this problem. Once you have several episodes of vomiting present, it's very difficult to turn this around. That's why it's very, very important. But the best management for these situations is prevention by knowing what I'm going to describe to you in the next few minutes is what I call the 6-day rule. When you're approaching that ER visit again, take your supplies with you whenever possible. Make sure you ask and expect clear explanations. Try to be calm and collected. Remember, the doctors there are really trying to help. And you know your child and yourself best. Make sure you work with the healthcare provider there as a team. And you really are the team leader, and you need to never forget that fact. Now, here's some problems I want to go over. And this starts one of the first problems here, and this may be very familiar to some of you. My 14-year-old teen with type 1 diabetes is feeling ill. The teen says the blood sugars are, quote, all right. My teen is now thrown up twice. What should I do next? Now, that's a common scenario. I get telephone calls from families quite a bit about this, and I have to work with that basic information. I'm going to tell you over the next several slides how we'd approach a problem just like this. So let's go on to a very practical situation. After awakening, your child with diabetes on an insulin pump says she's sick to her stomach, but it hasn't thrown up. You just changed the infusion site last evening. That's the site that infuses the insulin in the body. What do you do next? Do you measure her ketones, change the infusion site, check for air bubbles in the tubing, give her some anti-nausea medicine such as Amitrol, or check for blood sugar? Well, the answer in this case would be the first thing you want to do is to check her blood sugar. You want to know what's going on. Is this an extreme low blood sugar or is it an extreme high blood sugar? So very importantly, you want to get that piece of information so you can move on to the next step. Now, you check the blood sugar. It's 453.
Please use the mute button on your phones to mute.
Infusion out of her insulin pump. You, again, check for air bubbles in the tubing. You give her some anti-nausea medicine. Or do you recheck her blood sugars just to verify? Well, assuming you did it properly the first time, the best answer would be to measure her ketone. Because those are two pieces of very important information you need to know to take the next step in her treatment. Now, ketones are large by urine dipstick. Now what do? Do you give an insulin correction dose to the pump? Do you change the pump infusion site? Do you check for air bubbles in the tubing? Do you give a shot of rapid-acting insulin? Or do you give her some anti-nausea medication? Well, the best answer in this situation would be to give a shot of rapid-acting insulin. That needs to be given to reverse that high blood sugar, stop the production of those high levels of ketones that are circulating in the bloodstream. Now, let me give you some information that's real practical about dosing rapid-acting insulin. One method is to give the correction dose that has been assigned to you by your doctor or clinic. That's usually assigned as part of a ratio, or it may be part of an insulin pump calculation.
Please, if you don't know how to mute your phone, just please get off the call. We can't hear Dr. Ponder.
Your team is to dose your rapid-acting insulin based on body weight. And we're talking now about Lispro, which is Humalog, Aspart, which is Novolog, or glulisine, which is also called Atidra. These are all your rapid-acting insulins which are used for meals or to an insulin pump. Now, the way you can calculate this is actually determine that dose based on the body weight in kilograms. Now, I'm going to walk you through how you do this. 0.1 units of rapid-acting insulin per kilogram body weight. You take the weight in pounds, divide that by 2.2, and that gives you the weight in kilograms. You give 1/10 of that amount as rapid-acting insulin. Let me give you a practical example. Say for a 60-pound child, you divide them by that weight by 2.2, you get 27 kilograms. That's the weight in the metric system for that child. And you would give about 1/10 of that, 2.7, or approximately 3 units of rapid-acting insulin to that child as an injection. And an injection is important because you want to give that reliably. Giving it through an insulin pump could be problematic because the pump itself could be a problem. And we'll talk about that quite a bit. And I think that's one of the most common problems I see that puts people in the hospital is when they try to treat through an insulin pump too long and they get too far down the line and it's too late to recover. You give a correction dose of rapid-acting insulin by injection, as I said earlier, and decide to change out the infusion site and load fresh insulin. Very logical next step. She is sipping water okay. 1 hour after the shot, she hasn't vomited, but still feels queasy. Now, what do you think you ought to do now? Would you give her an anti-nausea suppository? Would you offer a trial of bland, solid food, such as toast? Would you take her to the emergency room now? Would you recheck blood sugar and ketones? Or would you give her another shot of rapid-acting insulin? Well, I think the best answer here would be to get more information. check the blood sugar and the ketones. That would be what your next immediate step would be, because you want to have lots of recurring information in regards to sugar and ketones to know which direction things are heading. So you do that. The blood sugar is 320 and the ketones are large. What do you do next? Repeat the shot with the same amount of rapid-acting insulin as the previous dose? Do you give anti-nausea medicine or another suppository? Do you offer a trial of bland solid food, such as toast? Would you take her to the emergency room right now? Would you use your smart pump to calculate or deliver a correction dose for the 320? Now, in my opinion, the best option in this situation would be to repeat the injection, same amount of rapid-acting insulin. Now, I know some of you would be tempted to go ahead and use a pump to do this. You might be fortunate, you might be lucky, and that might work. And I can't say that wouldn't be one option. If you want the best possible result, you like to give that insulin by injection, because then you're certain that it got in. And I think that's an important message to take, because I have lots of examples of people who continue to treat through a pump, even after the repeat pump insertion was non-functional. Now, you repeat another dose of rapid-acting insulin by injection with the same amount, as I mentioned. She continues to sip water while resting at home. She says she feels like eating. In another hour, her blood sugar is 210, and her ketones are still large. Now what do? You administer another rapid-acting insulin shot? You deliver a correction dose with the pump? You offer a trial of bland solid food, such as toast? You stop giving her sips of water? You go to the emergency room since ketones are still large? Well, in my opinion, it's okay to, at this point, start giving her something of bland food, assuming she tolerates it. She wants to eat, and she needs some carbohydrates for her metabolism. So I think this is a good next choice in that step. Just 1 second. Pause for 5 seconds, and let's let everybody mute. We're going to mute everybody from our end so we can stop all these additional noises. Thank you for your patience. They're going to find out it's their problem. Yeah.
People talking, that's so creepy.
Okay. I believe we've been successful. Now, she eats a slice of toast, water every 15 to 20 minutes. In another hour, her blood sugar is 163, and ketones are moderate to large. Her tummy is feeling better. Now, what would you do next? Would you deliver a correction dose? Would you continue bland foods, sips of water, and give bolus insulin for carbs? Would you go to the emergency room the present? Or would you keep checking blood sugar but stop checking ketones? Well, I believe of the 4 answers, the best one would be to continue giving her some bland food. She needs some energy to fight off this particular problem. Keep water to maintain her hydration. But hydration, having plenty of water in the system, is extremely important for ridding the body of extra sugar, as well as ridding the body of extra ketones. And, of course, give her some insulin to cover those carbohydrates. Bland foods and sips of water are continued. Bolus insulin is given for carbs eaten. You decide to check blood sugar and ketones every couple of hours. At the next check, the blood sugar is 131 and ketones are moderate. Her appetite is now normal. What do you do next? Do you think it's all right to go back on normal diabetes care routine now and stop checking ketones? Would you encourage fluids and check blood sugar and ketones every 2 to 4 hours until ketones are all gone? Would you increase the pump basal rate by 25% for 12 hours to eliminate ketones? Well, in my opinion, the best answer here would be to encourage fluids and check blood sugars and ketones every 2 to 4 hours until the ketones are all gone. You want to continue to follow through on this problem until you completely, utterly eliminate the ketones and normalize the blood sugars. One of the biggest shortcomings I see in managing this condition at home is a failure to follow through on this until all the ketones are completely eliminated, which means continuing to check for the ketones, whether by blood or by until they're all extinguished and out of the system. Now, another question in a different line of questions now. Which of the following high blood sugar and ketone situations might be managed at home? All of these cases have type 1 diabetes. Would it be A, a 3-year-old boy who has vomited 6 times this morning and won't eat or drink and has a blood sugar of 412, ketones in the blood are high? or a 12-year-old girl who has sharp lower belly pain and vomited 3 times with a blood sugar of 220 and ketones are traced. Or a 10-year-old boy with nausea and just 1 episode of vomiting, a blood sugar of 557 and large urine ketones. Or a 14-year-old girl who is hard to arouse and the blood sugar is not readable on the meter and you can't get
that's what they want to. This is exactly what I want.
Which of one of these 4 would you attempt to manage at home? Well, I think it's pretty obvious that the 10-year-old boy with just some nausea and maybe 1 episode of vomiting has the opportunity to be managed at least for a period of time at home. All of the others would need to be taken to an emergency department, contact a physician. Somebody would need to see that child quickly. Okay, let's stop for a second and let's see what we've learned so far. Just remember that high blood sugars may or may not be associated with ketones. That's a very important piece of information. I put that in the pre-webinar material as well. The presence of high blood sugar and high ketones means that insulin is needed immediately. That's a very important principle to remember and never forget. Again, this was part of our pre-webinar materials I had shared with you over the weekend. Frequent sugar and ketone rechecks are key to successful treatment. I made that point several times in the last few slides. You have to keep checking often and frequently to make sure your therapies are getting the results you want to see. Staying well hydrated and managing nausea is an ongoing process. You may need to use medications in some cases, but it's important to give small sips of fluid, provide some form of liquid replenishment, because the stages of diabetic ketoacidosis are basically steps towards a state of dehydration. DKA is also called dehydration. Very important. So reversing it involves maintaining good hydration with small sips of fluid and managing nausea. If vomiting can't be stopped, this is really your trigger to go straight to the hospital, call the emergency room, and call you in that emergency room. Vomiting is really a key factor in being able to manage these kind of problems at home. And remember that blood sugars will improve well before ketones will disappear. Many of you probably know this by experience, but the blood sugars will get better because it takes time for the body to reverse the ketone levels in the blood to make them completely go away. That's why it's so important to follow through with this for several hours. Sometimes it may take a whole day to clear the body of ketones. Okay, I'm going to answer one of the questions for you. What would the sharp lower belly pain indicate in the last example? That's a great question. Let me answer that. Not only do ketones get produced when you have no insulin in the system or low insulin in the system, but you get substances that are called prostaglandins that are produced in the body. Prostaglandins will cause cramping and nausea. In fact, they cause more of the nausea that occurs with diabetic ketoacidosis than do the ketones themselves. So you can get rather sharp, intense belly pain. And I've had some children have pain as severe as what they would think appendicitis should be. It's important if that occurs. That's usually going to be associated with a lot of nausea. And in those situations, yes, you would need to be seen and you would need to take your child in. But that's the cause. It's from something called prostaglandins, which are produced in parallel with ketone. And what else have we learned so far? That working on why this happens, as to what may have caused these high blood sugars and ketones to occur, usually happens as you're treating the situation. But don't waste a lot of time trying to figure out what happened while you're treating the problem. You can do that a little bit later. Never treat high blood sugars and ketones with an insulin pump first. And I think this is one of my take-home messages for the whole evening. I know we've had some audio problems tonight, but please never treat high blood sugars and ketones with an insulin pump. Always treat with an injection. It's the safest route. It's going to be the one that's going to get you in the least amount of trouble in the long run. High sugar and ketones on a pump is a pump problem until proven otherwise. That's also extremely important to remember as well. I just spent 2 weeks at a large diabetes camp, and most of our high blood sugar problems are all due to insulin pump issues, either disconnected sites, leaking pumps, air bubbles in pumps, programming errors, and the like. Now, ketones, just on a sidelight, are not bad. It's very important. We sometimes try to vilify ketones. They're actually a normal part of human biochemistry. We all need ketones. They're always present in us in low amounts. They are actually used as a source of brain energy. So we need ketones as part of our normal body chemistry. Non-diabetic people would be frequently hypoglycemic without ketones. In fact, normal life would be quite difficult if we lacked the ability to produce ketones. And just as a sideline, there are people in this world who have disorders where they cannot produce ketones, and they have significant problems with severe hypoglycemia. And like in those very scary movies, as I show here, especially the Halloween movies, I always would remind parents, you got to finish off the ketone man. One whack at him with a dose of insulin is not necessarily going to get rid of him. You have to follow through and completely eliminate him, as I said earlier. Now, let me give you some true and false questions to challenge you a little bit. If I or my child forget to take a mealtime insulin dose through a pump or shot, this will cause ketones to occur in the blood. So in other words, if I miss a mealtime dose, is that going to cause me to get ketones? The answer is false. At most, high blood sugar will happen because there's no insulin there to help metabolize the food that you're eating. If the basal insulin to the pump or the shot, if that's 11 Lantus, is working, this is enough insulin to prevent ketone production. It's not enough, however, to control the rise in blood sugar levels. But just remember, a missed meal dose rarely, if ever, will cause ketones. It's usually a missed dose of long-acting insulin or an interruption in the basal insulin rate of an insulin pump. Now, here's a situation question. A toddler with diabetes normally gets 5 units of NPH in the morning, 1 unit of NPH in the afternoon, and 2 units of Lantus in the evening. Now, this is maybe very old school to some of you, and some of you may have never heard what NPH is, but it's an intermediate-acting insulin. The father accidentally gets 5 units of NPH at 3 p.m. What should you do next? Now, this is from a real-life example I got just a few weeks ago. I think the answer is pretty straightforward. Just like with the other things I've said so far, you want to check blood sugars more often, at least for the duration of action of that insulin.
It's that hard to find the mute button on your phone.
12 hours, maybe a bit longer. And you want to check more often to make sure you catch a falling blood sugar and treat appropriately. You could also consider giving the toddler a larger meal for dinner to offset the more insulin, the greater amount of insulin that is in his system. And you still want to make sure you give your usual Lantus dose at bedtime, because if you withheld that, you'll be withholding a very important insulin dose that keeps his blood sugars in check through the night. So more frequent monitoring, perhaps some additional carbohydrates, more food in the evening would be the solution when you give an accidentally larger dose of insulin in this situation. Here's another question. I got a call from my ex-husband in California. Our 14-year-old daughter with type 1 diabetes spends 2 weeks with him every summer. This morning he called to tell me she was up all night vomiting. He said she told him her blood sugars were okay. Is she coming down? Well, that's not an uncommon call. I've had that call before as well. The answer here is I think, quite obvious to those of you that may have teenagers, and that is the first thing you want to do is check blood sugars, check those ketones directly. Especially with teenagers. They may tell you something they think you want to hear, but make sure you as an adult go in there and check that and make sure you know what you're dealing with. And you might need to be ready to go to the emergency room at that point, especially if she's been up all night vomiting. Remember, that's our red flag for needing to go into the hospital. You want to prevent that from happening at all costs. If that's the first thing you hear and somebody says they're having problems, if they vomited multiple times, that's the one thing that we can't overcome in a home setting, and you need to go seek professional help. Another situation. I just got a call from the EMS about my daughter with type 1 diabetes. Bystanders at the mall said she was acting strange and screaming obscenities at other people. She kicked the clerk and someone called 911. What do you think the reason might be in this situation? Well, in this day and age, teenagers, it could be a number of things, but the two most common things would be, of course, low blood sugar. You can't rule out substance use, and anybody in the
Ma'am, we can hear your conversation. It's very distracting.
Or it could possibly be both problems. But I think a low blood sugar is the first suspicion anyone would have of a person acting irrationally, whether a teenager, a child, or an adult. And very important to always check a blood sugar for somebody who's acting erratically. Very important situation. I've seen it happen many, many times. Another situation, following up on that, is the EMS treated her with IV sugar twice. Her sugar came up to 275 in 2 minutes, yet she was still acting irrational. Why do you think that's the case? This is very interesting, and not all of you may have had this experience before, but I can tell you why this happens. There's a lag time that happens before the sugar that's given into the bloodstream actually permeates into the brain and actually causes an improvement in a person's behavior. We see this a lot in the past at our diabetes camp when we've had to sometimes, occasionally, give IV sugar to a camper who has a low reading. Their blood sugar would be up rather quickly, but they would still be a little bit groggy, a little bit irrational. Now, of course, substances can't be ruled out in this situation, but there is a lag time between when the sugar increases and when the brain senses it. Or, of course, you could always have both problems present. And if there was some use of alcohol or other substances, that could also muddy the picture here as well. Here's another situation that many of you may have seen before. Your child with diabetes also has moderate to severe asthma. Her doctor just prescribed prednisone pills by mouth to help with a flare-up of her asthma, in addition to the other medications. What do you need to be prepared for? Now, many of you may have been down this path before, but let me explain a couple things. Prednisone is what we call a steroid medication, and many of you all know what steroids are. Steroids act to raise blood sugars. They do so by actually creating sugar internally within the body. Prednisone itself has no sugar in it. It actually induces changes in the body which acts to raise blood sugars internally by breaking down tissues within the body and converting them into sugar. You could also be possibly worried about ketones because the prednisone will antagonize the insulin. And even if you are giving the insulin properly, it could be a high enough dose where it could actually cause not only high blood sugars, but also ketones. So whenever you start a child or a person on prednisone, monitor blood sugars much more frequently. You may need to make significant adjustments in the insulin dose. How much? Possibly up to 100% in some cases. You need to check these readings frequently. Stay in touch with your team. If you've been trained how to do this yourself, you may find that more than just 1 or 2 units is what's necessary to increase it. It might be many units additional insulin to compensate for the high dose of steroid that may be given for some of these kind of flare-ups. Now, here's another situation. At midnight, my diabetic daughter had a severe low blood sugar. We heard her moaning in her room. Her sugar was 32, and she was incoherent. We injected her with 1 milligram of glucagon and called EMS. By the time they arrived, she was awake but nauseous. She went to bed early after dinner, and her dad had an argument. She and her dad had an argument over a new boyfriend. She wears an insulin pump. Now, this is another real-life example I've seen before. What can you do next, or what should you do next? Well, first of all, you're going to treat the problem. But the next thing you might want to do is check the insulin pump history. Make sure the dosages were given properly. Make sure that food was eaten properly as well, and that she had the meal she was supposed to eat.
Please mute your phone.
I have an example once of a young lady who took an overdose of insulin when she had a fight with a friend, and we found her 2 hours later having a very severe low blood sugar reaction. The pump history revealed the answer. That around 10:15, this teenager had taken 20 units of rapid-acting insulin surreptitiously in an attempt as an irrational act, I agree. But sometimes you can get valuable information by reviewing these pump histories to explain unexplained readings in terms of low blood sugars. What we call mystery boluses at diabetes camp. And also review the blood sugars that you have for this young lady to see if any changes are needed. Maybe she's trending low a lot already and already needs to have a reduction even before this happened. So that's another possibility. That's how you would troubleshoot a situation like that. Mystery boluses. We see a lot of these. And these happen. These are boluses of insulin that are taken and not shared with anybody. We see them at our diabetes camp. I've written about them many times. It's something that parents can sometimes discover if they are careful at looking at bolus histories to make sure that the proper amount of insulin is being given. Oftentimes they can be missed boluses as well, where there's no record whatsoever of any insulin being given through an insulin pump. That's a part of the insulin pump which is often very underutilized and very underappreciated. Now, what about low blood sugar and nausea? Now, I've talked about high blood sugar and nausea. You have a 3-year-old with diabetes who is very fussy and has a blood sugar of 58. He refuses to eat or drink anything you offer him. Should you take him to the ER or call EMS? What else can you do? Well, for many of you, if he won't eat, you might well put him in the car and take him to the local emergency room. There's another option, however. Many of you may have used the mini-dose glucagon protocol. I'm going to explain that next. This is a very valuable tool, and hopefully some of you know this or maybe even use this, but many of you this may be a new phenomenon to you. Mini-dose glucagon is for treating non-severe low blood sugar with nausea, usually in younger children, typically toddlers and small children. It requires careful attention by the parent or the caregiver that's using it. I'm going to explain to you how you use it. In mini-dose glucagon, you prepare the glucagon like you normally would to treat a severe low blood sugar. That is, somebody who's incoherent, on the verge of having a seizure, having twitching movements, and so on, which basically is to prepare 100 units of the water solution called a diluent, mix that into the 1 milligram of powder in the vial of glucagon, do the full dilution. But with mini-dose, you give 1 unit for every year of age between age 3 and 15. So I'll give you an example. You have a 3-year-old, you give 3 units. If you have an 8-year-old, you give 8 units. If you have a 2-year-old, you'd still give 3 units because the lowest dose you give would be 3. If you had a 17-year-old, you'd give 15. So you give no less than 3 and no more than 15. But again, it's 1 unit for every year of age. You would check the blood sugar in another 30 minutes, and if it's still under 100 milligrams per deciliter, you would repeat the injection with the same amount. Now, if any time during this experience that child or that person has a more severe reaction, you would go ahead and give the full dose of glucagon like you've been instructed to do. But the mini-dose glucagon protocol is very valuable for raising blood sugars from this 50-ish, high 40s, 50 range, not to the point that these youngsters are about to pass out, but they're just being cranky and irritable, and it can bring them up to a level where they're more agreeable and willing to eat for you. So it's a very valuable tool. Please file this away in your toolkit for future use. Now, here's another situation. It's 3 a.m. You go to check your child's blood sugar. She wears an insulin pump. The sugar is 427 milligrams per deciliter. What do you do next? Well, I think by now most of you are knowing what these answers should be. You want to check the ketone. You want to make sure there's something not going on with that pump. Again, I'm giving you a lot of valuable information here about a very common problem.
To unmute your line, press *6 or #6.
Insulin pump problems can include a dislodged site that gets pulled out during sleep, an improperly inserted site that was put in during a routine site change, an infected site, which can occur at any time, any air bubbles that can accumulate in the tubing, which result in no insulin delivery, heat-damaged insulin, which in hot environments can be a significant problem and can result in loss of insulin function, especially if you wear the reservoir for an extended period of time, especially outside. Programming errors. Sometimes kids will play games with their pumps and they may accidentally zero out the basal rate, which itself could cause a significant problem because there would be no insulin going in for basal needs, which could result in high blood sugars and ketones. Or a skipped bolus. Just remember, I asked you this question before, and I gave you the answer for this, but a skipped food bolus is not a reason, but it certainly enables things. And people that have pump problems from skipped boluses are generally going to have high blood sugars, but rarely will they have ketones associated with that. Now, here's some clinical examples. These are pictures I've taken from numerous cases. You can see these infusion sets and how this one was bent. It was inserted, but it was not infusing properly. Another one. These are all that have been taken at my children's diabetes camp. They've been removed from campers. Again, this site's not functioning properly. Here's another curled, bent site. No insulin was getting into the wearer in this particular case. This one is interesting, and I'm going to expand this picture. You can see that indentation on the skin there, which I'm highlighting with the graphics here. That was actually the infusion catheter laying sideways on the skin. It had never really penetrated into the skin. It was laying there for roughly a day before this child presented with diabetic ketoacidosis. Again, another bent catheter. These catheters are very, very tender, and they're prone to being torn or not inserting properly, as you can see here. And I would imagine that a number of people watching this have examples of their own like this with any of a number of different infusion sites. And here's another classic example. This was actually taken in the intensive care unit. You can see where the arrow shows that catheter is basically at a right angle to where it should be, and it never even penetrated into the skin. And this individual had put this pump in 24 hours earlier, came into the emergency department vomiting multiple times over the afternoon, had not checked blood sugars carefully, which is one of the problems, And this was a severe case of diabetic ketoacidosis, as you can see, caused by a poor infusion site procedure. And I think I've shown you several of these. Now, here's a good example of air in infusion tubing. When you hold the tubing up and hold it up to a light, you can actually see air bubbles or air gaps. Make sure you do that every time you load the pump. Whenever I load my pump, it takes me about 10 up to 15 minutes to make sure I purge the air. I make sure everything is in perfect working order. There is no advantage to loading and inserting a pump quickly, in my opinion. And here's an example of air in the Rurlock hub of an insulin pump as well. And that bubble could find its way into that tubing. And again, at the rate these basal rates run, could result in several hours of no insulin being delivered, which in turn could cause not only a high blood sugar, but now, as many of you know, ketones to occur as well. Now, this individual just loaded 120 units of air, believe it or not. This was an incredible picture I took of a child who didn't even load their pump properly. There was nothing in there but air in that pump. Here's another example of tubing. These are devices which can be defective, and the tubing had separated from the connector and was leaking, and you could smell the odor of insulin on that tubing, which you should not smell. There's another process called tunneling, and it's a problem with some of these Teflon infusion sets, and that's back leakage of insulin. The insulin coming out of the end of the catheter actually leaks backwards, back up towards the surface, and it's typically seen when the site's been in there for several days, and there's been a lot of movement at the site. And so you don't get the full amount of insulin into the patient, into the person wearing this. It often happens in tennis players, golfers, and others that have vigorous, rather quick, sudden movements in their bodies who are wearing insulin pumps on their abdomen. It's often a good idea to make a tape sandwich of sorts or use metal sets, for those of you that use pumps, that might help keep this from happening. But this is not an uncommon problem. And here's an example of a tunneling example I have, just to show you. See that small hole in the middle there? There was actually insulin oozing out of there when we removed that site. It was just not going in properly. That site had been in there for several days. You can see the indentation, that circle that's present there, which suggested somebody had worn their site a bit too long. Now, what have we learned so far in this last segment? That insulin pumps are very complex devices, and they can malfunction or be misused in different ways, either skipping boluses or taking extra boluses. Never, and again, I say this the third or fourth time, never trust a pump to treat high blood sugars and ketones. Always go with your injections and or even a bottle of new insulin is needed. When in doubt, change it out. And uncontrolled vomiting means go to the hospital ASAP. Nausea, maybe the first episode of vomiting, call for help or at least get into high gear and start attacking that problem early on, as we talked about earlier. Now, here's another situation. My 12-year-old son with diabetes just threw up unexpectedly after lunch, and his stomach hurts. What should I do next? He is very responsible, and he takes his own shots. Now, that's a loaded term right there. It doesn't matter how old they are. It never hurts to have a grown-up recheck the blood sugar and ketones anyway, just to make sure. Always better safe than sorry in these situations. Another situation. It's been an hour after lunch on the weekend. Your teen son ate 3 large slices of pepperoni pizza and took 15 units of Novolog. That's the most the pump would allow in that situation. He was next door playing basketball for about half an hour with his friends. Now he's feeling sleepy and is laid down on the sofa. Why do you think that's going on? What would be your most likely explanation for that? Is it that pizza makes us drowsy? Is it a spiking sugar level from the pizza? Is it ketones from the fat that were in the pizza? Is it an insulin-food mismatch, or could it be a pump malfunction? Well, in all likelihood, given how slow pizza is to turn into glucose, it's most likely an insulin-food mismatch. That insulin that he took, which was made stronger by the exercise, was dropping his blood sugar rather dramatically, giving him a very sleepy, tired-feeling loss of energy, which was hypoglycemia. Even though there's plenty of carbohydrates in his system, that pizza takes time to turn into glucose, and there's a mismatch there. So he'll have an immediate low blood sugar that may occur 45 minutes to an hour after the pizza was eaten and the insulin was taken, which may later rebound up to a much higher reading, especially in response to all the treatment that needs to be given to treat the low blood sugar that occurs about 45 minutes to an hour later, which is made worse, of course, by the exercise. Here's another situation. Your daughter with type 1 diabetes plays third base on her high school softball team. Her team has played games all day long and has advanced to the state finals. Her blood sugar at the end of the last game was 210. What considerations should you have in this situation? She takes Lantus and Novolog shots. Now, those of you that have athletes probably know the answer to this one. This is called post-exercise hypoglycemia. Now, that doesn't mean she's going to have this, but it's something that she's at risk for. And it's estimated that roughly 1 out of 3 people with type 1 diabetes are at risk for having these sort of situations occur. And I'll explain how this works. We have a large organ in our abdomen called the liver. It's responsible for storing and releasing sugar. We use all of that sugar up during prolonged activity or exercise, like what I showed you in the previous example. And it takes time to replace all of that sugar. And if that sugar is being put back in the liver, insulin is not necessary for that. So not only do you have the insulin that this child is receiving that will lower her blood sugars, but you also have the liver, which is acting like a sponge and pulling out the sugar from the bloodstream, adding an additional lowering force on the blood sugar level, which occurs well after the exercise has occurred. So the treatment for this would be to increase the snacks, especially in the evening, because post-exercise hypoglycemia notoriously happens during the night after an extended period of exercise. You could also possibly reduce the long-acting or the basal insulin, whether that's by injection or through a pump. And certainly most of you would most likely check a blood sugar at midnight and 3 a.m. to catch a low blood sugar should that occur. But this is not at all an uncommon problem, and there are ways to mitigate it, to prevent it, by increasing your food intake and possibly reducing your insulin as well. Here's another situation I think everybody should pass on this one. Your 10-year-old son is scheduled to have a plantar wart removed by the podiatrist. He wears an insulin pump. How should his diabetes be managed during this procedure? This is a pretty straightforward, no different than anyone else. Most plantar warts aren't going to be removed under any sort of general anesthesia procedure. They're going to be outpatient procedures. Because this is on the foot, and a 10-year-old, he does not have any greater or lesser risk of having circulation problems that many of you may think occur in people with diabetes, but is not a problem in a 10-year-old. So there should be absolutely no difference how you would manage this young man to remove his wart by the podiatrist. If you're doing a procedure that involves some sort of anesthesia or some period of time where you're asked not to eat anything, ideally those should be done first case in the morning, especially if it's an elective case. Oftentimes they may ask you to not eat anything all day long, which can be really challenging for a person with type 1 diabetes because of the risk of low blood sugar. So whenever you have the option, please always make sure you schedule your elective surgery to occur first case in the morning. Another situation, my 16-year-old daughter with type 1 diabetes was diagnosed 3 years ago. She developed a skin infection on her foot from an insect bite and is now on several antibiotic pills prescribed by her doctor. Does she need to do anything different for her diabetes? Could this cause her to lose her leg? Well, another good question, but here's basically what you have to do. Like anything else, when you have a change in routine, check the blood sugar more often. Make sure you check for ketones, of course, if you have a high blood sugar of, say, over 300. And then her leg should be fine in time. Again, 16-year-olds with type 1 diabetes have excellent circulation. They will heal just as well as any other 16-year-old, just like the 10-year-old would do fine with the plantar wart compared to any other 10-year-old. Now, I get some FAQs here I'm going to try to answer for you in the final stages here. Why can blood sugars go so high sometimes? Sometimes people will report blood sugars as high as 1,600 or 2,000 or higher. First of all, this is not a category in the Guinness Book of World Records. Blood sugars are measured relative to the amount of water in the bloodstream. So, in other words, the higher the blood sugars, the more dehydrated you are. So please remember that. Just hydration alone can bring a 600 blood sugar down to 300 or 400 relatively quickly in the total absence of insulin. That's why hydration or water is such an important first step when we have ultra-high blood sugars, even more so than giving insulin in some cases. Now, another question. How often should I check blood sugar during an acute illness? Well, first of all, you want to check it often, at least hourly at first. You want to know what direction that blood sugar is heading. Now, if you happen to be fortunate and have a sensor of some sort, you will want to check that every 20 to 30 minutes to check for a trend line to make sure which direction your blood sugar vectors are heading. You want to check ketones hourly if you can. if you have a high blood sugar that has any ketones present. You want to keep following those until you've completely eliminated them, as I said earlier. Check things less often as you get more comfortable that the trends are improving in the direction you want them to, that you're normalizing. But never let up until some sort of normalcy is reestablished. Now, can I treat high blood sugars and ketones with my insulin pump? I think you know the answer to this. I'm going to put this, I'm going to preface this by saying some people may still want to do this, but I will advise you the smartest thing to do is always use injections. Don't try to treat high blood sugars and ketones on an insulin pump. The reason is obvious, and I've said this now for the fourth time. In most cases, they are due to some problem with the pump, either the tubing, the site, and it's always wise to go with injections in these situations. Now, here's an example about can I rely on my CGM sensor during diabetic ketoacidosis? Here's a friend of mine who shared an example where his sensor in the top left-hand corner discovered a skyrocketing increase in blood sugars shortly after a new site, a few hours after the new site was inserted. And it was corrected all by injection, as you see on the slide below. And the culprit was an unremoved cap on the catheter. The cap had not been removed, and therefore the catheter did not go in the skin. It was laying sideways on the skin, and virtually no insulin was going into this person. Now, the final thing is I'm going to give you some tips. These are all very, very valuable tips that I hope you can take and use as you approach new problems that may occur with your diabetes or your child's diabetes. Why is insulin usually less effective when sugars are high and ketones are present? Well, the reason's obvious, and not obvious, but I'm going to make it obvious to you. You have a temporary insulin resistance that occurs when your blood sugars are high and ketones are present. It's temporary. There's also a phenomenon called glucose toxicity, and that's part of this. Your body does not respond the same way to insulin when you have high levels of sugar. Also, higher levels of anti-insulin substances, also known as anti-insulin hormones, are also present in the body when you have high sugars and ketones, which make it harder for insulin to do its job. Plus, finally, dehydration or loss of body water makes insulin harder to absorb from the injection sites or the infusion sites it's given. So that's those are the four primary reasons you might find that your usual insulin dosages don't seem to have the same impact that they do when you're not hyperglycemic or having high ketones. Now, why do the ketones come down slower than the blood sugar can come down? Well, remember, ketones are lost through the urine. They can also be breathed out through the lungs. They're also turned into other things inside the body. That process takes time. The conversion of ketones back to other substances takes time. Now, sugar is also lost in the urine, but it's also driven back into the muscle, fat, and liver by insulin much more quickly than ketones can be converted back into their basic substances, too. Plus, you can burn up the sugar for energy, and they don't burn the ketones as quickly. And also, when you have insulin on board, you're producing less sugar internally because insulin is stopping that process from occurring. Remember, when you don't have enough insulin, you start overproducing internal insulin as well. So again, this speaks back to what I said earlier about the on-off role of insulin. When you have insulin present, it turns on the uptake of sugar. It turns off the production of ketones. Now, another tip. It takes less insulin to arrest ketone production than it takes to control blood sugar. You might be surprised to know how much, about 1/10 as much. So if we have ketones present, we know there's a significant insulin gap present. That's why it's so important to stay on top of this, add additional insulin as needed, and aggressively and frequently as needed. Another tip, totally normalize sugars and eliminate ketones before resting. And stop and remove those ketones with extreme prejudice. Again, the biggest mistake I see families and individuals make in the years I've been treating diabetes is a failure to follow through after they've treated once or twice, not to make sure the ketones have been completely eliminated by increased drinking as well as frequent dosing of insulin as needed based on the blood sugars and the rules of what we call the sick day rules, which are outlined in the video I shared with you this last weekend. Another tip, as you treat an extreme high or low blood sugar, at some point try to figure out what might have caused the situation. And that's fine. You might want to troubleshoot that insulin pump or that site. But remember one thing. Don't waste valuable time. Don't take it away from treating the immediate problem. You have to get those blood sugars down. You have to flush those ketones out. That should be job number one. Figuring out what happened, you can be Monday morning quarterback later on. But please make sure that you fix the immediate problem Don't waste valuable time, or you may be loading up and going to the hospital. Here's some little things that sometimes get overlooked that should cause major problems. Not discarding opened insulin after 1 month of use. Avoiding prolonged exposure of insulin to high heat or freezing temperatures. I saw a post the other day of somebody who left their insulin in 100-degree heat for an afternoon. Well, you don't want to use that, obviously. You don't want to freeze it either. Dosing insulin and forgetting to eat on time. I've done that before where I got distracted and it caused a low blood sugar. So you have to remember these are the little things that will oftentimes get us in trouble. Making too many changes on an insulin pump at once because we think the pump's going to fix everything can also be a problem. Oftentimes it's not necessarily the pump, but maybe how we're using the pump. As I said earlier, the timing, or whether we're counting the carbohydrates properly. Not double-checking a blood glucose, a high blood sugar before correcting. You can actually have false highs. I've seen a number of families post images of blood sugars that were several hundred, only be rechecked later and be in the 80s or 90s. So if you don't see somebody who has the signs and symptoms of a high blood sugar, it's always wise to repeat that. Also, that could also be due to not cleaning the hands before checking the blood sugars, especially in young kids who may have all sorts of contaminating substances or sweet things on their hands. So always make sure you clean those hands before you check those blood sugars. Some other very, very valuable tips. Don't try to blame everything that happens on the diabetes. There are other things that can cause blood sugars to go kind of crazy besides just the diabetes itself. Timing, poor carb counting, as I said earlier, insulin problems, unexpected exercise. There are lots of things besides just diabetes that will cause erratic blood sugars. Ignoring pump and sensor alarms can be very, very catastrophic. Make sure you pay attention to those when you hear them go off. Overtreating a low blood sugar, not filling a pump cannula after insertion. I've seen that happen with kids as well. That means there could be up to a 1-hour gap or so in insulin delivery, especially if the pump is delivering at a very slow rate. And I've actually seen children prime their insulin pumps while the tubing was attached to them. I've seen adults attempt to do that as well, not thinking when they did the priming, which could easily result in a large dose of insulin being delivered through an insulin pump. Not having an off-pump insulin regimen or a backup plan can also be challenging as well. We try to make sure everybody has a backup insulin regimen in our practice. And it's important to have one of these with you at all times in case your pump breaks down. Not using the insulin pump temporary infusion rates for illnesses. You can increase the rate of insulin delivery in a pump during illness to offset the stress effect of that illness and keep the blood sugars in better control. Also, not having a source of fast-acting carbohydrates within reach can cause problems with low blood sugars. Keep fast-acting carbs in the house at all points around your office, in places that, in backpacks that can be easily reached, don't have to be searched for later on. That could make a big difference between a mild low blood sugar and a severe low blood sugar. Not checking ketones for high blood sugar levels is a common problem. Oftentimes people will have 300, 400 blood sugars and nobody checks ketones because they think that they're immune to ketones. Unfortunately, nobody is immune to developing ketones. If you don't finish the bolus cycle on some pumps, you'll miss getting a dose. And sometimes an additional button is pushed on some of these pumps, which aborts the insulin delivery. Not checking blood sugar after a site change to make sure it's working is a very important omission that causes problems. After we change a site at our diabetes camp, kids always have a blood sugar check 2 hours later to make sure their sugars are not rising, which would indicate the site is not working. And I've shown you plenty of examples of that. Skipped or omitted shots I've discussed. Inconsistent blood sugar checks without attention to what the number is saying. In other words, that's a very common problem. A teen may say, I have a 350, and nothing happens from that information. That could be a significant piece of information that could result in preventing an episode of diabetic ketoacidosis. Somebody only checked a ketone level after that. Assuming immunity to ketosis, not possible. Nobody is really immune to ketosis. Just because you haven't had it over and you checked 300 times doesn't mean on the 301st time you may have one. So just please don't get to that point that you think you can't get ketones or your child can't get them. Intentional insulin omissions for weight loss and body image issues, not uncommon in some teenagers, and also lacking the emotional maturity for self-care. Some of the kids that we in the practice can sometimes be too young to take on these responsibilities of self-dosing insulin, whether by shot or by pump, and that can cause significant problems. Now, how often can I take rapid-acting insulin? Well, if you have a protocol that your doctor's given to you, it's whatever the doctor recommends. At a minimum, you want to check blood sugar and ketones every 2 hours and act when you're ill, when you're not feeling well, and especially after you take a dose of rapid-acting insulin for an emergency situation. Always check to see what results you got. Some docs, like myself, will advise even hourly injections during an illness with hourly blood and ketone checks and callbacks. That's how I'm usually able to keep people out of the hospital, is by more aggressive insulin therapy. But if you just treat once and expect that to remedy the problem, oftentimes you may run into problems with that. Just remember. Now, when you treat at home, here's some tips. If you have no major symptoms and you're alert and awake, you can try to manage this at home. If you have just some mild nausea, you certainly can manage this at home as well, at least for a while. If you vomited once or twice and you're able to keep trying, then that's a depend. You can probably manage kids like that or yourself at least for a little bit longer before you have to possibly go to the hospital. But if you're appearing ill, you vomited 3 times or more, the advice is go to the hospital. You need to go ahead and go. That's why monitoring the nausea and the vomiting is so important in determining whether you try to manage a problem like this at home or go to the hospital. Or if you're just not sure what to do, it's always valid, of course, to go to the emergency department to get further evaluated. If that vomiting cannot be controlled, call for help. My preference to all the patients out there, whether they're mine or other doctors, is if your child or you are nauseated, act then. That is the crossroads. That's the fork in the road, so to speak, that you want to take and to not go down the path towards diabetic ketoacidosis. But if you see somebody who can't stay awake, who's having fast, deep, labored breathing, or if they're having on the flip side the severe lows, including twitching or seizing, you're obviously going to call for emergency help at that point. You're going to give glucagon if you think they have severe low blood sugar. But even if the child or person just isn't looking right to you, it's okay to go ahead and seek professional help. It's better safe than sorry. Now, the sick day rules that I summarized for you and actually go over in my 17-minute video, which I posted over the weekend, are summarized here. Make sure you check blood sugar often during any illness. Measure ketones until they're all gone. Again, I've said this several times tonight. Drink plenty of fluids. Hydration is key. Treat nausea aggressively. Take scheduled insulin. Don't omit insulin. In fact, illness often demands more insulin to prevent diabetic ketoacidosis. And that means taking extra insulin as needed based on the instructions you receive from your team or your training. And also knowing when to call for help. And finally, as I wrap up the presentation here, give yourself credit for what you do well. There are a lot of you out there who are very good at what you do and have lots of experience in this area. And I think that you should recognize that. I think many of you probably could add a lot to this talk and have already been asking some excellent questions I'm going to try to answer in the remaining minutes. I want to thank you, and I hope you really have learned a few things. More importantly, how to act early and aggressively with any illness or any extreme in blood sugar with the main intent of trying to keep you or your loved one out of the emergency room, out of the hospital. So I'm going to stop. I'm going to, in the remaining time left I have, which is about 20 minutes, I'm going to do my best to answer all the questions that have been accumulating while I was speaking. And it looks like we have quite a few. The first one goes as follows. Isn't it important to bring down high blood sugar slowly? How do we do that at home? That's an excellent point. If somebody comes in and they have a very, very elevated blood sugar, you can give them fluid hydration with sips of water, which by itself will actually bring blood sugars down. But if you give a large dose of insulin all at once, some concern, especially if the blood sugar has been high for many, many hours or even days, is that it could cause some problems. There is a rate of speed that you would like to bring blood sugars down by. Generally speaking, no faster than 100 points per hour. That's considered the upper limit of how fast you want to drop a blood sugar. Again, about 100 points per hour. That's 100 milligrams per deciliter per hour. You can do that, of course. Most likely with the doses you're giving, you're not going to see the same results you would normally see in terms of the dropping power of an insulin dose when they're not having high sugars and ketones, for the reasons I outlined earlier, that your body is resistant to the insulin. But whatever your correction dose is your doctor's given may or may not work, and it's important to check that, because what I've seen happen a lot is correction dosages sometimes can be highly variable in how effective they are, and they don't always correct. Let me remind you that a correction dose should be checked at least 2 hours after it's given. Now, if you have nausea and you think your child has significant problems leading into DKA, you might want to check them hourly, as I said, and certainly at a minimum call for help in that situation, because if you called me, I would more than likely ask you to check every 30 minutes to an hour, stay in close contact, and make more aggressive insulin moves than probably what you would get given to you on a recipe. But that's a very good question. Now, next question is, what about interruption of the basal hemolymph for a few hours when swimming? Have to disconnect the pump. Should I attach the pump each hour to deliver it, or is the increase in activity enough to offset it? How long would the basal have to be interrupted to increase ketones? Excellent question. Generally speaking, you don't want to be disconnected from the insulin pump for more than 2 hours. Most of us that wear pumps, myself included, will actually reconnect on an hourly basis. I think that's a safer approach, but the maximum limit is roughly 2 hours. Every hour, and take a small bolus that would be equivalent to perhaps half of the basal rate, because you have to remember the exercise is going to act or augment, if you will, the insulin that's in there being delivered as basal. So you may not need as much. So if you were wearing the insulin pump, you would probably turn the basal rate down, say 30, 40, even 50% for a lot of intense physical activity. So the one way you can copy that or mimic that by reconnecting would be to give the same amount of insulin as basal, but reduce that amount and give it every hour. So I think that would probably be the safest way, is to reconnect every hour, give about half the amount you would normally get as basal for a lot of intense physical activity such as swimming. That's a great question. Other questions are, when using expired glucagon for training, for me and the family, the capsule never completely dissolves. I know in real life I would be freaking out. Is it okay to inject without totally dissolving, or maybe is this an expired glucagon issue? I will tell you, I've measured, I have reconstituted glucagon many times. It does reconstitute rather quickly, especially if it's not expired. That should not be a problem. It usually goes into a very clear solution in just a matter of seconds, quite frankly. So if you did have one that did not do that, it would be problematic to know whether or not you're giving them the right amount. So my answer to this is I've never seen one that did not go into solution quickly in just about 15 to 30 seconds tops. This could be an expired glucagon issue, to answer your initial question. Next question, for the after-exercise snack, do you cover it with insulin or not? I generally don't. If it's an after-exercise snack and I'm using it to replace the carbohydrates burned during the activity, I generally don't cover that. The general rule of thumb for giving snacks for an activity is as follows: roughly 15 grams for every 30 minutes. There's a lot of variability in how people respond to that, and it also depends on the intensity and the duration of the activity. So if you're playing tennis versus running versus lifting weights, you're going to see different results. And so the wisest thing to do is start with something small, make adjustments, check your blood sugars frequently to determine what best works for your unique exercise activity. Next question, my son tends to spike with intense exercise, especially if it's something exciting like a judo tournament. I assume this is adrenaline. Is there anything I can do besides to keep correcting? My advice to you about this is this is related to glucagon in some ways. Glucagon and adrenaline both act to raise blood sugar levels. That's what they do. They work by different mechanisms, but they both increase the blood sugar. And an exciting event like judo or some sort of physical activity, many of you will see your teens have their blood sugar spike. Many of you also know that correcting those can sometimes be kind of disastrous, because I call that a hollow high, is what I call it. It's not a high that's due to a large amount of food that's in the system. It's due to moving out a lot of sugar that's stored in the liver and other parts of the body and just flushing it through the bloodstream. And it will just pass through fairly quickly. And many of you may have actually watched the blood sugars fall in the following 2 or 3 hours. So my advice to you in terms of whether you correct that or not is, if you do, you have a much smaller correction in those situations. You might even try a 50% correction at first with careful checks afterwards if you think it's an adrenaline high. Or, in some cases, some parents will just opt to just wait for it to come down over the next few hours and deal with it that way, as opposed to risking an over-treatment of an adrenaline high. Next question, can you address the best way to handle low blood sugar with ketones? when sick with the flu? Well, I tell you what, low blood sugar with ketones is generally not a problem. Ketones are actually a normal byproduct of your metabolism. And when you have low blood sugar, your body's actually using ketones for energy. So you're not going to go into diabetic ketoacidosis from a low blood sugar. I'll just tell you that. That's totally impossible to do. And so I'm not sure I would worry too much about those ketones. You might want to certainly stay well hydrated. You might want to make sure the blood sugar is treated properly, and you bring that low blood sugar up back to a more desirable target range. But the stress of the illness and sometimes the lack of food intake during an illness can cause some of these ketones to occur. So getting carbohydrates into the person who's sick, at least even in liquid form, is a good way to turn off those ketones from being produced and also get the blood sugar back up to a more desirable range. Next question, what would be considered high ketones in testing blood? That's a good question. General rule of thumb is when your ketones are getting up into the 0.6 or higher, 0.6 or higher range, you're going to want to consider adding additional insulin. I showed some examples on the slide deck. Most of you, if you check your ketones, may have 0.1 or even 0.2 ketones under normal circumstances. The one I showed was my ketones when I had a blood sugar of 95 and I had 0.1 ketones. So we all have ketones in our body to some level. When you start treating for these, there's actually a recommendation if you have a ketone meter, and it recommends anything over 0.6, you start seriously considering adding insulin to treat that like you would for a moderate or large urine ketone level. Next question, how many times per day should we check ketones during sick day management? Frankly, anytime you have over 300 blood sugar, that's the recommendation. You may have been taught 250, that's fine too, but you just need to check. You need to have a heightened sense of awareness for these things because they can occur at any time during the illness. And if they occur, they can put you in a big hole. So you have to change your game on sick days. And so the general rule of thumb is any blood sugar greater than 300 milligrams per deciliter, check ketones. And again, I may sound like a broken record on this, but just because you haven't had them in the past doesn't mean you can't get them, and you don't want to find out the hard way. Next question. Our endo is adamant about waiting every 3 hours to correct any issue ketone high blood sugar since we are on injections. I understand this. Many of you have been taught not to give insulin between meals. I will tell you that your body is always making insulin, and if you have a high blood sugar, there's going to be a need for insulin. But I do understand that some physicians are reluctant to try to educate families to do this. I don't want to put you at odds with your endocrinologist and what you've learned tonight. I will tell you that in my practice, I am more inclined to recommend supplemental rapid-acting insulin when the criteria that I described earlier, namely high blood sugars and ketones, are present. And in fact, I often find that fairly frequent dosages are needed in order to turn around a deteriorating situation. That's my approach. I've been doing that for approximately 30 years, and it's a very effective approach. But again, I don't want to get sideways with your endocrinologist on this. If you have somebody who has a certain way of doing things, I need to defer to how you've been taught in that regard. But in my practice, I do it a little bit differently, as you can tell. Next question. Can we use Zofran that is technically expired in order to avoid the ER? Well, I think you know what I'm going to say here. On a forum like this, any expired medication should not be used. You should contact your physician. If necessary, get an emergency prescription filled at a 24-hour pharmacy. There are other forms of anti-nausea medicine, even over-the-counter medications like Emitrol that can be used as well. But I would not recommend formally to use expired medications under any circumstances. My next question is, my son was diagnosed in April 2012. He refused to try to give himself injections, but insists he's ready for a pump. Is a pump a good idea? He's now age 11. An insulin pump is a great way to bypass injections. It's a great way to dose frequently with insulin. If you look at it that way, I'm not saying it's a great way to maintain excellent control, and I say that in all honesty. To maintain excellent control, you can do that with a pump or without a pump. A pump provides all sorts of new options, but the person that's wearing the pump needs to be trained in those options, and an 11-year-old still needs very close adult supervision. I just came back from a camp where we had many 11-year-olds and even younger on insulin pumps. I will tell you that many of them were not in the best control. That's not because of anything more than the fact that these are still 11-year-old kids. They make 11-year-old decisions, and unless they have adults at their side helping them, guiding them, supporting them, a pump is no better or worse than the human being or child that it's attached to. I'll leave that as my answer. Next question. Are correction doses maxed out around 300? Even if my son is 400 plus, I still take the same dose. If we increase the correction to match more than 300, he bottoms out. Thoughts? Well, I think there is an upper limit on how much we want to give people, and we can give additional dosages. And I think that that speaks to what I just addressed before about the endo not wanting to give more than one dose every few hours. Is that personally, I think that it makes little sense that I can give one correction dose, and that's going to remedy everything. A correction dose should be checked in 2 hours, and if it's not resulted in the desired result, another dose should be considered. That's my professional opinion for that, and that's how I've always practiced. And so you can perhaps give too much, as this example points out. So maybe giving smaller doses more frequently with more careful monitoring would be the better answer than to give a large whopping dose all at once and result in having this bottoming out event occur. Next question is, are high ketones possible at a closely watched low blood sugar? He wears a CGM. Just overnight, it's sometimes impossible to get him to safe levels. I think that low ketones are going to occur in people with low blood sugar. It happens. It's not going to cause ketoacidosis. Remember the slide I showed you which said we don't want to vilify ketones. Ketones are an important part of human physiology. We need them. Let's don't focus too much on ketones when we're running low. It's really the ketones that we're running high that are going to get us in trouble. Ketones when we're running low just mean that we are trying to use alternate sources of energy to run our brains and our bodies. And we need that. That's actually a good thing. So when you have ketones with a low blood sugar, don't consider that necessarily a bad event. Please don't. I have a couple more questions. At what blood sugar should I give a full dose of glucagon in the event my child will not eat or drink? He is 8 years old. Excellent question. Well, I will tell you, in my experience, usually giving a second dose of the mini-dose glucagon in 30 minutes usually will correct the situation. But if that child or that person becomes incoherent, starts to show any evidence of seizure activity, twitching, irregular movements and such, you give them the full dose at that point. But mini-dose glucagon is only used for mild low blood sugar that's associated with some degree of nausea and or reluctance to eat. That's the intent of that low dose regimen. But if you have any suspicion whatsoever about whether the child is responding properly or not doing well or taking a nosedive, you go ahead and give the full dose. Remember, glucagon takes about 15 to 20 minutes to work. It's not unlike insulin. It has a delayed effect. So please remember that. It's not going to be immediate. And you're, of course, not injecting it into a vein. You're just injecting it under the skin as well. Next question is, when my son gets high ketones, he is able to clear them by drinking 36 to 48 ounces of water. He is able to clear ketones in about 30 minutes. Are we hurting by gulping lots of water? Absolutely not. If you drank lots of water over a long period of time, you could possibly get water intoxication. I understand where you're going with that question. But you don't mention how old your son is, but sipping water, taking small gulps over a period of time is the best way to do it. And clearing ketones in 30 minutes is not necessarily a record we want to set, but you're doing the right thing, which is staying hydrated. You don't want to take too much water in because sometimes the prostaglandins I mentioned earlier can be associated with nausea, and they can cause you drink too much, you can get distended, you can then throw up, and that pretty much sets you back. So really, drinking about 8 ounces every 20 minutes is not at all unusual, and that's a recommended maximum amount. So I think that's probably a bit more to gulp that much water in just 30 minutes. So I would recommend probably backing off a little bit on that. Obviously, it seems to work for you, but the recommendation from the medical end would be to aim for about no more than 8 ounces every 20 minutes. And in fact, I have a screen on the sick day video which you can freeze frame, which highlights based on age and size how much water, how much fluid to take in, and how often to do it, so you don't overhydrate somebody or distend their stomach to the point of nausea and vomiting. So, last question. And I appreciate everyone's patience here with tonight's webinar. My son is honeymooning. After meals, he often spikes above 300. Should we check for ketones every time? Okay. Well, this is interesting. These are two things that seem a bit contradictory. The word honeymoon basically means that this young man is still making insulin. Yet, if he's spiking over 300, that speaks to the fact that he may not be making as much insulin as you think. And you might want to recheck the definition of honeymoon and see if he's coming out of that phase. But if anybody spikes over 300, again, the recommendation is to check for ketones. This is just to be totally safe. If in most cases of honeymooning, there's still some residual insulin present. That usually is enough to keep you out of ketoacidosis if you're taking a basal insulin along with it, such as Lantus 11 or on a pump. But a spike of over 300, again, I will fall back and I will give you the recommendation, which is to go ahead and check those ketones. It's the smartest thing to do, better safe than sorry, and respond accordingly. Folks, I really appreciate your time. We are about 2 minutes to closing. I want to thank you for your patience. This is our first webinar from Baylor Scott & White. We're going to be doing more, and we will have a lot of these audio issues that we had tonight worked out for the next one. So I apologize for that. This webinar has been recorded and will be made available through my website, my Facebook page, The Power Within by Stephen Ponder. Please go to that site, and I will post the links to the pre-webinar material, the sick day video, tonight's PowerPoint. I will put that post up there, as well as the recorded version, the link to the recorded version of this talk. It will take about a day or so to process the recorded version of tonight's talk for you, but it will be up there. So please access these at your convenience, and I want to hand over to our moderator, who will close out our session tonight. Thank you very much for your attendance.
Thank you, Dr. Ponder, for covering the topic of how to deal with extreme sugar levels in an organized way. Today's webinar will be available to review and share on our homepage at swchildrens.org. That's swchildrens.org. Please share it with your friends and others in your personal community of care, and look for more webinars in the near future from Dr. Ponder and McLean Children's. You can follow Dr. Ponder on social media. Follow him on Facebook, on Twitter at Stephen Ponder MD, as well as follow his blog, The Power Within. The address is StephenPonderMD.com. That's StephenPonderMD.com. This concludes our program for today. You may now disconnect.
The reader has disconnected. The conference will be terminated in 2 minutes. The leader has disconnected. The conference will now end.